Hi, thank you for joining us. I'm Dr. Phoebe Thorpe, and it's my pleasure to welcome you to the CDC Public Health Grand Rounds for August 2016 on Neonatal Abstinence Syndrome. We have a very exciting presentation, so let's get started, but first, a few housekeeping slides. We do have continuing education credits available. Please see our Public Health Grand Rounds website for more information. We also are available on all of your social media websites, and we are tweeting today, so please use hashtag CDC Grand Rounds for any tweeting needs. We also have a featured video segment called Beyond the Data that has my interview with Dr. Stephen Patrick. It will be posted by the end of the week. It is a short video with take-home messages. We also have featured science clips posted with the CDC Public Health Library. It's available at cdc.gov/science clips. Here is a preview of the upcoming Public Health Grand Rounds sessions. Please join us live or on the web at your convenience. And in addition to our outstanding featured speakers, I'd like to take a moment to acknowledge the important contributions of the individuals listed here. Thank you. And now a few words from CDC's director, Dr. Frieden.
Thank you very much, and thanks to our speakers for being here. This is a really important topic, and I want to welcome you all to this Grand Rounds. The U.S. is in really the midst of an epidemic of opiate abuse, overdose, and death. It was exactly in this room 6 or 7 years ago that I first heard a succession of problems that struck me that it was not just one part of our society that was at risk. We heard about one of the few, perhaps the only area of health where the death rate is increasing rapidly in the U.S. If you look at all causes of death through NCHS, the opiate overdoses really stand out. We've seen, going back a few years now, clusters of both hepatitis C and HIV related to opiate addiction and then use of injection drugs. We've even seen increase in drugged driving and falls among seniors from opiate addiction, and we've seen neonatal abstinence syndrome. And we know that the number of people who've died from opiates has quadrupled over the past 15 years, and that has paralleled almost exactly the increase in opiate prescribing. Opiates are dangerous medications. You take a little bit too much and you can die. You take just a few doses and you can be addicted for life. We haven't got the risk-benefit ratio right in our assessment of when they should be used and how they should be used. There are lots of ways we're trying to address that. First, to protect people who are not yet addicted from addiction. And second, to provide services in terms of both addiction treatment and pain management for those who are or may be addicted to opiates. Yesterday, I took the pledge and joined the U.S. Surgeon General's campaign to turn the tide and end the opioid crisis. This is a campaign that seeks to educate clinicians, screen patients, and discuss addiction as an illness. Neonatal abstinence syndrome is yet another reason why we have to end this epidemic. Today's speakers will give you a good sense, a good overview of the scope of the problem, and you'll hear about some of the work that we at CDC are doing along with partners. This improves improving the information that we have, so we're getting real-time information about problems that evolve very quickly, whether it's new formulations of opiates coming into the community, for example, non-pharmaceutical fentanyl, or increase in heroin and heroin overdoses, or prescribers or patients who are using medications at dangerous levels. We need real-time information for real-time response. Second, we're strengthening state efforts by scaling up interventions ranging from rapid responses to improving prescription drug monitoring programs, which have a lot of potential, which is as yet not fully realized. And third, we're supplying healthcare providers with the resources to improve patient safety, including our guidance that you'll hear some about today on prescribing that weighs the risks and benefits of opioids and recognizes that these are indeed dangerous medications. You'll also hear more, of course, about neonatal abstinence syndrome. We need to learn more about what are the most effective ways to screen and care for women who are pregnant and who are on opioids. But there are things that we can do now to change it. One of the most startling findings that you'll hear about is that 1 out of 3 women of reproductive age are prescribed an opiate. That's a startling number. We need to change that reality dramatically. Now, even among pregnant women, that number may be as high as 1 out of 5 and not lower than 1 out of 6 currently. So we need to do a lot more to address the overall use of pregnancy, but of opiates overall, including in women who may be pregnant or who become pregnant. But there are also very specific things that need to be done to address neonatal abstinence syndrome in terms of both the detection and the treatment, and I'm very much looking forward to this afternoon's session. Thank you.
And now for our first speaker, Dr. Wanda Barfield.
Good afternoon. Today I'll be providing an overview of the problem of neonatal abstinence syndrome, what it is, increasing trends, and how they relate to the opioid epidemic, and why a public health approach is needed to prevent it. Neonatal abstinence syndrome, or NAS, is a drug withdrawal syndrome in newborns who have been exposed to certain substances in the womb prior to birth. Symptoms most commonly occur within 48 to 72 hours after birth and can include tremors, hyperactive reflexes, seizures, excessive or high-pitched crying, irritability, yawning, stuffy nose, sneezing or sleep disturbances, poor feeding and sucking, vomiting, loose stools, dehydration, and poor weight gain. Also increased sweating, temperature instability, and fever. In utero effects of NAS may include poor fetal growth and preterm birth. Postnatal effects of NAS may include prolonged hospitalization, including neonatal intensive care unit admission, poor postnatal growth, dehydration, and seizures. It is unclear whether NAS is associated with developmental delays, and long-term studies on possible developmental effects of NAS are needed. NAS is most commonly attributed to opioids during pregnancy. Exposure can be either from prescription pain medications such as Vicodin, OxyContin, Percocet, from illicit substances such as heroin, or from opioid maintenance therapy such as methadone or buprenorphine. Maintenance therapy is the long-term treatment for opioid use disorder under medical supervision with a longer-acting but less euphoric opioid. Opioid maintenance therapy is recommended by the American College of Obstetricians and Gynecologists during pregnancy. Other substances, such as cocaine, amphetamines, and barbiturates, have been implicated with NAS. It is important to note that the terminology related to opioids in literature and clinical use are different, and so here are the main terms that we're going to be using during this session. Opioid use is defined as taking an opioid to reduce pain. Abuse or misuse of opioids is taking these drugs without a prescription or in a manner that is directed by the prescriber. Dependence occurs when an adaptation to opioids produces symptoms of withdrawal when opioids are stopped. And opioid use disorder is a problematic pattern of the use of opioids leading to clinically significant impairment or distress. There has been a significant increase in the prevalence of NAS from 1.2 per thousand U.S. hospital births in 2000 to 5.8 per thousand U.S. hospital births in 2012. This is equivalent to an increase of just under 3,000 infants infected in 2000 to almost 22,000 infants in 2012. In 2012, on average, 1 infant was born every 25 minutes with NAS in the U.S. NAS incidence rates vary by geographic region. In the dark blue states here, including Kentucky, Tennessee, Mississippi, and Alabama, as the most affected geographic region in the U.S. These states have between 15 to 20 NAS cases per 1,000 hospital births. CDC recently released a study on state-specific NAS incidence. Among the 28 states included in this report, NAS incidence ranged from 0.7 cases per 1,000 hospital births in Hawaii to 33.4 cases per 1,000 hospital births in West Virginia in 2013. The dark gray states on this map had the greatest incidence of NAS, over 30 cases per 1,000 hospital births in 2012 and 2013. Neonatal Abstinence Syndrome reflects our current prescription opioid epidemic in the U.S. In 2016, colleagues at the CDC's National Center for Injury Prevention and Control noted increases in drug overdose deaths in the U.S. general population, driven largely by opioid overuse deaths since the early 2000s. The prevalence of maternal opioid abuse or dependence among pregnant women during hospitalization for delivery has increased 127%, from 1.7 per 1,000 delivery admissions in 1998 to 3.9 per 1,000 delivery admissions in 2011. And for women of reproductive age, between 15 and 44 years of age, opioid prescriptions are common. During 2008 to 2012, over a quarter of privately insured and nearly 40% of Medicaid-enrolled women filled a prescription for an opioid each year. Ideally, prevention of NAS could occur by preventing opioid use prior to conception. However, nearly 50% of all pregnancies among women and girls 15 to 44 years of age in the U.S. are unintended. It is estimated to be even higher, approximately 86%, among women who abuse opioids. Women who may be dependent on opioids may not initially know that they're pregnant. Considerable numbers of exposed infants require pharmacologic treatment to wean from opioids. Treatment is based on minimizing symptoms of withdrawal, including evidence-based approaches to managing these symptoms through AAP guidelines, for example. Assessment tools and scores to manage the treatment still remain suboptimal, but improved models of care are emerging, and you're going to hear about this a little bit more from Dr. Patrick. The mean length of stay for an NAS infant is 23 days, and the mean hospital charge is $93,400 per infant, accounting for an estimated $1.5 billion in direct healthcare expenditures, which Medicaid is the most common payer at $1.2 billion. So neonatal abstinence syndrome is not just about the baby. A public health approach is needed to prevent opioid abuse, misuse, dependence, and use disorder across the lifespan, not just for the neonate infant, but for the pregnant mother, women and men of reproductive age, prior to conception, our youth and older adults. Thank you for your attention, and now I'd like to introduce Dr. Cheryl Broussard.
Good afternoon. Today I'll be speaking with you about where the steps that can be taken to prevent NAS fit into the bigger picture of preconception health. Opioids are widely used among women of reproductive age in the United States. CDC reported that from 2008 to 2012, on average, about 1/3 of reproductive aged women, regardless of insurance type, filled a prescription written by a healthcare provider for an opioid medication. Published U.S. estimates indicate that from 14 to 22% of women receive an opioid prescription during pregnancy, and this is based on retrospective cohort studies covering 2000 to 2011. As Dr. Barfield mentioned, over the same time period, there has also been an increase in the prevalence of opioid use disorders among pregnant women. Along with prescription use, the misuse and abuse of opioids in the United States has increased dramatically in recent years among women of all ages. As this graph shows with the magenta line, women have had a more than 400% increase in prescription opioid overdose deaths since 1999, which is notably higher than overdose deaths due to other prescription and illicit drugs that are shown on this graph. And for every opioid overdose death, there are 30 more emergency department visits. That means that every 3 minutes, a woman goes to the emergency department for prescription opioid misuse or abuse. And this is most common among women between the ages of 25 and 54, which includes the prime childbearing years. CDC is working to reverse the prescription drug overdose epidemic by focusing on 3 areas. First, protecting the public's health by improving data quality and tracking trends to monitor the epidemic. Second, CDC is strengthening state efforts by helping states target and tailor public health prevention resources. Finally, CDC is working to improve patient safety by supplying healthcare providers with data, tools, and guidance for evidence-based decision-making that improves population health. One example is CDC's recently published guideline for prescribing opioids for chronic pain. Sometimes the prescription becomes the problem. To reverse the opioid and NAS epidemics, we need to improve the way that we treat pain in order to prevent abuse, addiction, and overdose before they start. Longer durations and higher dosages of opioid treatment have been associated with opioid use disorder, so the guideline advises to start low and go slow. Some of the recommendations included in the CDC guideline apply to primary care providers of pregnant women and those who could become pregnant. These recommendations include, for non-pregnant women, before initiating opioid therapy for chronic pain, discuss family planning and how long-term opioid use might affect any future pregnancy. Besides NAS, opioids used in pregnancy can be associated with additional risks, including preterm delivery, stillbirth, and potentially some types of birth defects. For pregnant patients, primary care providers should carefully weigh the risks and benefits when making decisions about whether to initiate opioid therapy. Additional recommendations for primary care providers of pregnant women include, for those with opioid use disorder, medication-assisted therapy with buprenorphine without naloxone or with methadone has been associated with improved maternal outcomes and should be offered. Access appropriate expertise if considering tapering opioids during pregnancy because of the possible risk to the patient and fetus if the patient goes into withdrawal, such as spontaneous abortion and premature labor. Although there can be regional access issues for either this expertise or for medication-assisted therapy for pregnant women. For pregnant patients taking opioids for maintenance therapy or for pain management, arrange for delivery at a facility prepared to evaluate and treat NAS. Within the United States, prescribing rates for opioid pain medications vary widely from state to state. The 13 highest prescribing states are represented here by the dark purple color. In 2012, healthcare providers in the highest prescribing state, Alabama, wrote nearly 3 times as many opioid prescriptions per person as those in the lowest prescribing state, Hawaii. Earlier studies suggest that regional variation in use of prescriptions cannot be explained by the underlying health status of the population. Prescription drug monitoring programs, or PDMPs, are state-based databases of controlled prescription drugs dispensed by pharmacies. These databases were created to detect high-risk prescriptions and patient behaviors, and programs are currently in 49 states. They contain critical clinical data that can help identify patients at risk for opioid-related overdoses. Patients receiving opioids from multiple sources and patients being prescribed high total dosages of opioids account for a majority of opioid-related overdose deaths. These 2 risk factors can be easily determined from PDMP data if providers can access and review these data. PDMP data can also inform providers of other medications the patient is receiving that may interact with those prescribed and can identify patients struggling with opioid use disorder. Obstetrician gynecologists could be a target provider group for raising awareness and utilization of PDMPs for better tracking of opioid use among pregnant women and those planning pregnancies. But all healthcare providers should consider risks and benefits when prescribing these medications to reproductive-aged women. Primary prevention of NAS through reduced opioid use among women will also contribute to prevention of other opioid-associated adverse pregnancy outcomes, including preterm birth and potentially some types of birth defects. This graph shows that CDC is making some progress towards our goal of reducing opioid use among women of reproductive age and pregnant women. The latest estimates using 2013 commercial claims data indicate a prevalence of about 24% among reproductive-aged women and about 10% among pregnant women. Although data from 2014 forward are not yet available, CDC has set targets which, if met, would show further decreases in opioid use among women of reproductive age and pregnant women. Even before women and their partners think about becoming pregnant, there are upstream opportunities for prevention of NAS. Another opportunity for primary prevention is to reduce unintended pregnancies among women with opioid use disorder. As Dr. Barfield mentioned, the rate of unintended pregnancy overall is high, nearly 50% in the United States, but even higher, 86% among opioid-abusing women. There is an unmet need for increased access to effective contraception, both pre-pregnancy and post-delivery in this population, including support for long-acting reversible contraception, such as IUDs and implants. Treating for Two is CDC's national strategy to improve the health of moms and babies through safer medication use in pregnancy. Our strategy includes 3 focus areas: better research, reliable guidance, and informed decisions. Through this initiative, we've been encouraging all prescribers and pharmacists to consider that they might be treating for two when prescribing or dispensing medications to women of reproductive age, and to discuss and advise accordingly. Expanded research, evidence-based guidance, and informed decision-making are relevant to both medication and contraceptive choices. The National Preconception Health and Healthcare Initiative is another opportunity to contribute to primary prevention of NAS. Their vision is that all women and men of reproductive age will achieve optimal health and wellness, fostering a healthy life course for them and any children they may have. Through improved preconception health care and appropriate opioid prescribing, we're ultimately hoping to have public health impact across multiple audiences. For patients, the aim is optimal treatment for both pain and opioid use disorder before and during pregnancy to ensure healthier moms and babies. For prescribers and pharmacists, the aims are responsible patient care and more effective patient counseling. And for CDC, health departments, and health systems, the intended impact is improved ability to decrease misuse of prescription drugs. State health agencies can also support education and awareness efforts to increase provider-patient discussions about the risks of opioid use and opioid use disorders, including the potential risks to infants exposed in utero to these drugs, and the importance of contraception to reduce unintended fetal exposure. In summary, strategies to improve preconception health and evidence-based prescribing can be implemented at the provider, patient, and population levels. While some progress is being made in decreasing the rate of opioid prescribing, more progress is needed. One aim is optimal treatment, including maintenance therapy for women with opioid use disorder. Because rates of unintended pregnancy remain high, broader use of long-acting reversible contraception is also an appropriate intervention for many women of childbearing age who may be prescribed opioids. Thank you. It's now my pleasure to introduce the next speaker, Dr. Kimberly Yonkers.
Thank you very much, Dr. Broussard, and good afternoon to everyone. Now I'd like to turn to screening and treatment of women who may use substances in pregnancy. Screening, or what we refer to as case finding, can be useful, but there's a certain depth to the issue that we need to appreciate. especially when it comes to vulnerable populations such as pregnant women, and particularly pregnant women who may use hazardous substances. When we peel off these layers, we see that there are questions for which we either have limited or no data to guide our practices. First, which women should be screened? Screening all pregnant women can be expensive and time-consuming. It may also be a deterrent to some women who may have concerns about the consequences of screening. However, women who are in need or need help with substance use will be missed if screening is relegated to just certain populations. Second, what substances should women be screened for using? Some substances, such as opiates, about which we're speaking today, are used relatively less commonly, but they may be associated with very problematic outcomes for both mom and her offspring. Other substances are very common, but are associated with some of the most negative outcomes for children. For example, ethanol can cause fetal alcohol syndrome or fetal alcohol effects, which are associated with severe neurocognitive deficits. Third, when should women be screened? The use of substances varies across pregnancy, and the same individual may be positive at one point and negative at another. There are some additional methodological and policy challenges posed by screening during pregnancy. How should a person be screened? Via computer, which may yield higher response rates than a person, or by a person who can couple screening with treatment? What are the consequences of screening? In some states, a positive screen for an illicit substance triggers mandatory reporting to Child Protective Services. Finally, what screening instruments should we use? Now, I want to focus a little bit more on these issues, and let me begin with who should be screened. Certain groups are deemed to be high risk based on our research. For example, women with a prior history of substance use are more likely to use substances in pregnancy than women who have never used substances. Another high-risk group is adolescents. Studies show that adolescents have particularly high rates of substance use, which may be related to their becoming pregnant in the first place. Other studies show greater risk for a variety of groups, such as women of color or women of lower SES, socioeconomic status. But there are also lessons to be learned. For example, a landmark study from 1990 conducted in Pinellas County, Florida, showed that urine screening of pregnant women yielded similar rates of positive tests in white and black women. Unfortunately, women of color were 10 times more likely to be reported to Child Protective Services than were white women. In the end, race was not the operative risk factor for reporting substance use, but socioeconomic status was, but I think this provides lessons to us all. The flip side of this is that for many women, pregnancy is the rare contact with the healthcare system. If handled appropriately, screening may provide a chance to engage women in treatment. For this reason, as well as avoiding disparate treatment for some groups, broad screening protocols may be appropriate. When should we screen? Women's use of substances is well documented to change along the course of pregnancy. The highest rates of abstinence are attained toward the end of pregnancy. Data from my lab show that over 80% of women were able to stop the use of at least one substance by the end of pregnancy. Some women who temporarily attain abstinence may still benefit from referrals because of the risk of relapse right after delivery. If screening is conducted late, these women may be missed. On the other hand, other women may be able to achieve sustained abstinence, and early screening may lead to unwanted consequences, such as a report to Child Protective Services. If we decide to adopt screening protocols, we should think about how screening should be conducted. Biomarkers can be used to screen for substances, but their limitations need to be recognized. Urine is easily accessible, but it has a limited window of detection so that it can only show use, for example, in the previous few days. Urine screening is particularly poor for some substances, such as alcohol. Blood has an even more limited window of detection for most substances. Hair has a much broader window of detection and can detect use throughout pregnancy, but it's expensive and results can be influenced by a variety of factors, including things like hair treatment. Meconium and umbilical cord assays have a broad window of detection, but they are expensive and limited to the postpartum period. Saliva is also accessible, but tends to focus on one substance at a time. And in addition, there's some reliability issues with those assays. Questionnaires, on the other hand, have a number of strengths. First, they have very flexible screening windows. So, for example, we can ask women about the prior 7 days, last month, or the entire period of pregnancy. Questionnaires can also ask about a range of substances, including substances that may not be included in the typical biological assay. Questionnaires can promote dialogue about substance use and help connect a woman to specialty treatment. And questionnaires are inexpensive. However, substance use that is highly stigmatized, such as what we're speaking about today, the use of opiates, are particularly likely to yield a negative self-report. This points to the importance of determining the best questions to ask. Women may be more likely to admit to remote use of a substance than recent use, and questions along these lines can be particularly helpful. The reliability of screening measures for pregnant women have been evaluated very sparsely, and only a handful of instruments have shown any level of replication. The CRAFT is an acronym for the screening questions CAR, relax, alone, forget, family, friends, and troubles. The 4 Ps includes questions from 4 domains, which ask questions related to parents, partner, past, and pregnancy. A sample question is, have you ever drunk beer, wine, or liquor? The Wayne State Indirect Use Screener asks questions that indicate high risk without directly asking about all substances. In this way, it attempts to minimize underreporting because of perceived negative consequences. A sample question is, in the past year, I have smoked at least 100 cigarettes. The Substance Use Risk Profile in Pregnancy Scale is a brief screener and includes 3 questions. It was developed from a cohort of pregnant women. A sample question is, in the month before you knew you were pregnant, how much beer, wine, or liquor did you drink? A 3-site CDC study will assess the performance of these questionnaires in 1,200 pregnant women. Sites include Yale, Wayne State, and the Massachusetts General Hospital, and they were selected to reflect a broad socioeconomic range. The study includes a number of components. First, pregnant women are administered 5 screening questionnaires in a counterbalanced order. Then participants are assured of confidentiality, asked whether they understand and are comfortable with the questions in the screeners, and they're invited to provide a urine sample that tests for a range of substances. Finally, the performance of the 5 instruments will be compared, and we will use statistical techniques to build a new predictive measure. This slide shows some early data from the first quarter of the study cohort. Overall, about 30% of women submitted urines that tested positive for either a legal or illegal substance. Detection rates were high for metabolites of cannabis, which is shown in this slide, THC. Although the rates of opiates was lower, it's still notable even in this small sample. I want to briefly touch upon treatment. Behavioral treatments may be helpful for a range of substance use and should always be considered. We do not have pharmacological treatments for all substances. However, for women who are dependent upon opiates, current evidence-based guidelines recommend that they be treated with medication-assisted therapy alongside counseling. The medications that are recommended include buprenorphine and methadone. A landmark study showed that both medications helped pregnant women stop illicit opiate use. Although when moms were treated with buprenorphine rather than methadone, babies had a shorter hospital stay and shorter duration of medical treatment. A treatment that fits in nicely with screening is screening and brief intervention and referral to treatment also known as Iceberg. There are various forms of Iceberg, but most include a motivational interview that helps patients generate their own reasons for addressing their substance use and accessing other specialty treatment for substance use. Despite the magnitude of the problem, we still don't know the best approach to screen for substance use in pregnancy. Underreporting is likely common, and reasons for this are understandable, especially given some state policies. Efforts should be made to avoid stigmatization and focusing on any particular population. In other words, universal screening should be embraced. Detection of substance use in pregnancy should be coupled with assistance in obtaining specialty treatment for substance use. And now I'd like to introduce Dr. Stephen Patrick.
Well, thank you. It's an honor to be speaking with you today. To close our session, I'll focus on hospital, state, and federal policies aimed at improving care for women with opioid use disorder and infants with neonatal abstinence syndrome. And I'll finish with a potential path forward. The rapid rise of opioid use disorder among pregnant women and infants with neonatal abstinence syndrome has caught many communities off guard, especially those with a high prevalence of these conditions. However, responses to the prescription opioid epidemic have not explicitly included pregnant women and their infants. In part, this may be because the evidence base for clinicians, hospitals, and governments to address this vulnerable population is lacking. Today, there is substantial variability in clinician, hospital, and state approaches to neonatal abstinence syndrome. And what's needed is a coordinated, system-wide approach to optimize outcomes for this vulnerable population. NAS remained a relatively rare diagnosis until recently. So therefore, hospitals were ill-prepared to deal with a problem that now accounts for up to 50% of some hospitals' total annual hospital days. In a recent study of the nation's largest children's hospitals, our group found substantial inter- and intra-hospital variation in treatment and outcomes for neonatal abstinence syndrome. For example, we found a twofold difference in risk-adjusted length of hospital stay between hospitals. Beginning in early 2013, the Vermont-Oxford Network, a large international perinatal quality improvement network of hospitals, began a project to improve care for mothers with opioid use disorder and infants with neonatal abstinence syndrome. And at the beginning of this collaborative, many hospitals lacked basic policies for caring for infants with neonatal abstinence syndrome or substance-exposed infants. For example, only 45% had a policy to standardize scoring to help identify an infant with drug withdrawal. Less than half had a policy on breastfeeding a substance-exposed infant. And only 68% had a policy to guide pharmacologic treatment for infants with neonatal abstinence syndrome. In another recent study of nearly 10,000 infants with neonatal abstinence syndrome from almost 300 NICUs around the United States, treatment variation is also evident. On the graph here, you'll see on the y-axis percentage of infants treated with a particular medication, and on the x-axis is year. And overall, you can see a steady increase in the use of morphine and a relative decrease in the use of phenobarbital. But you can also see substantial variability from hospital to hospital. Overall, what's needed is standardization of practice and research to help guide the standardization. And we know that standardization works. There's 2 recent studies that show the power of consistent use of a protocol and development of policies. The Ohio Perinatal Collaborative sought to determine in a statewide cohort which medication worked better for neonatal abstinence syndrome, morphine or methadone. And they found no effect of drug choice, but what they did find was a large difference in length of treatment when an infant was exposed to a protocol-driven versus a non-protocol-driven wean, with a difference of nearly 15 days of hospital stay. And similarly, the Vermont-Oxford Network found that participation in the large collaborative increased standardization of care as evidenced by hospital policy and protocol development. And network-wide, there was a decrease in length of treatment by 1 day and length of stay by 2 days. And they found that hospitals that had policies specifically focused on scoring an infant to help identification had the lowest lengths of stay. Well, just as hospitals have struggled with dealing with the rising demands for medical care among opioid-exposed infants, many states have also struggled. And in particular, states have struggled with a public health versus a criminal justice approach to substance use in pregnancy. One state, Tennessee, allowed for criminal prosecution of a woman if she used an illicit narcotic in pregnancy. And still others are using laws first crafted to protect children from methamphetamine production to prosecute women for using substances in pregnancy. And 18 states consider substance use in pregnancy itself to be child abuse. However, just 12 states prioritize pregnant women for substance use and treatment. And it's also notable that implementation of the Child Abuse Prevention and Treatment Act has been quite variable from states. There was a report by Reuters in late fall that found substantial both provider and state implementation of safe plans of care for infants after they were discharged home. In this article, they found about 110 cases of infant deaths following discharge from neonatal abstinence syndrome. And beyond the apparent controversy, what's needed is a comprehensive approach, one that focuses on primary prevention of substance use, then prioritizes and facilitates treatment for pregnant women, and balances the need of keeping the family engaged with also keeping the child safe. I thought I would share my state, Tennessee, as a case example. As we've seen earlier on previous graphs, Tennessee ranks second in the nation in opioid prescribing. And as a result, our research suggests that Tennessee has a rate of neonatal abstinence syndrome that's 3 times the national average. Well, in 2013, the Tennessee legislature passed what I would call a carrot for women to engage in treatment. It sought to ensure that family-oriented drug abuse or drug dependency treatment was available, and that if a woman engaged in treatment by the 20th week of pregnancy, there would be no prosecution and no child removal just for a history of drug misuse. But then in 2014, the legislature passed Public Chapter 18, which was more of a stick approach. The law stated that a woman could be charged with a misdemeanor, punishable by a year in prison if she illegally uses a narcotic during pregnancy and if the baby's harm, and harm was defined as including neonatal abstinence syndrome. And there was substantial concern by many in the medical community, including myself, that women would avoid care altogether if they feared prosecution. And further, like many states, adequate access to treatment, particularly for pregnant women, remains a substantial challenge in Tennessee. And after much discussion and 2 years in effect, the stick part of this law sunset this past July. Well, let's transition to talking about federal policy. And I want to begin with the White House Office of National Drug Control Policy's 2011 plan to combat the prescription opioid epidemic. Well, the plan has 4 main parts, beginning with education. Education of parents, youth, and patients. All too often, patients and the public feel that opioids are safe because they're prescribed and they're a pill. And as Dr. Frieden said earlier, we know that not to be true. They are potentially dangerous medications. Requiring prescribers to receive education about appropriate and safe use and provider storage and disposal of prescription drugs, including opioids. It wasn't that long ago that I was in medical school, and the amount of education that I received on addiction and opioids was relatively small. Certainly more work to do there. Working towards monitoring, that every state have a prescription drug monitoring program, and working towards sharing and exchanging data between state or interstate operability. Today, as Cheryl mentioned before, 49 states in the United States have a prescription drug monitoring program, and since the ONDCP's plan was released in 2011, there's been substantial progress towards interstate operability. Some of our work suggests that this is working. We published a study earlier this summer that found that prescription drug monitoring program implementation was associated with a decrease in overdose deaths, opioid-related overdose deaths. And in particular, states that updated their data more frequently or monitored more drug schedules had greater reductions in overdose deaths. Proper medication disposal, to develop convenient and environmentally responsible prescription drug disposal programs to help decrease the supply of unused prescription drugs in the home. Oftentimes when I talk to moms and engage them in conversation when their infant's being treated with neonatal abstinence syndrome, we have conversations about when their dependency began. And it's not uncommon for me to hear about dependency beginning with a medicine cabinet in adolescence. And so beginning to take back these medicines has a critical role when we think about primary prevention. Since that time, DEA has continued to have drug take-back programs, and in 2014 released a rule to help facilitate take-back at both pharmacies and police stations. And enforcement. Provide law enforcement the tools necessary to eliminate improper prescribing practices in pill mills. And pill mills are a facility where you go in and have a limited evaluation and you walk out with a bottle of pills. In many communities, particularly Florida, this was problematic. There's some evidence to suggest that policies like pill mill specific legislation in Florida has been effective. Well, there has been recent attention focused specifically on neonatal abstinence syndrome, and I'll highlight a few specific actions. In February 2015, the Government Accountability Office released a report entitled Prenatal Drug Use and Newborn Health. Federal efforts need better planning and coordination. And what they found was NIH funding from 2008 to 2013 was $21.6 million. And as Dr. Barfield shared earlier, in 2012, hospital charges alone, just for neonatal abstinence syndrome, and the birth hospitalization was estimated to be $1.5 billion, a pretty stark contrast between the two. There are 14 federal programs that provide direct services to women with opioid use disorder and infants with neonatal abstinence syndrome, but the GAO found that coordination of HHS-wide efforts was needed, and that there was risk that federal efforts may be duplicated, overlapping, or fragmented. Well, shortly after the release of the GAO report, a bipartisan group from both the House and Senate introduced a bill called the Protecting Our Infants Act. The bill asks the Department of Health and Human Services to review and improve coordination within the department, to develop a strategy to address gaps in research and federal programs, to study and develop recommendations for preventing and treating prenatal opioid use and neonatal abstinence syndrome, and to improve data and a public health response by providing support to states and tribes. Well, this bill passed both the House and the Senate unanimously and was signed by the President shortly before Thanksgiving, the same day that he pardoned turkeys. But even more recently, Congress passed legislation called the Comprehensive Addiction and Recovery Act. The act encompasses a broad approach to prevention and expansion of treatment, including pregnant women and children. It bolsters PDMP by reallocating funds or reauthorizing NASPR. But the law also reauthorizes a grant program for residential treatment for pregnant and postpartum women with opioid use disorder. It provides providing services for women and children, including those with NAS, and it creates a new pilot program so states can support family-based services for pregnant and postpartum women and their children. The bill requires the GAO to issue a report on neonatal abstinence syndrome with a specific focus on Medicaid and how Medicaid may be involved in part of the solution. And it also included a really important provision on infant plan of safe care, specifically to disseminate best practices to states and improve monitoring and oversight of state implementation of these practices. This law was signed by President Obama in July, but notably without substantial funding from Congress. Many of the elements require allocation that has not occurred to date. And there are some other notable changes that merit mentioning. First, the Food and Drug Administration created a black box warning for both immediate and long-acting opioids so that women can know that there may be a risk of neonatal opioid withdrawal syndrome, as they term it, if they chronically use opioids in pregnancy. I've had the experience of taking care of a baby who had drug withdrawal, whose mom was chronically taking an opioid for headache, and she had no idea that neonatal abstinence syndrome could occur. Educating the public is important. And then SAMHSA crafting evidence-based guidelines for the treatment of women with opioid use disorder and neonatal abstinence syndrome, the first part of which were released earlier this month by SAMHSA. As we look forward and think about what the future should look like, I think it's important that we think about a public health approach to prenatal opioid use and neonatal abstinence syndrome, beginning with primary prevention, including access to contraception, responsible prescribing, tobacco cessation. Some of our research suggests that an opioid plus tobacco enhances the infant's risk of drug withdrawal, so tobacco cessation itself may be a primary prevention measure of NAS. Secondary prevention, including Iceberg, as was mentioned earlier. Tertiary prevention, decreasing variability of the treatment that I described earlier, and preventing readmission. Some of our work suggests that infants with drug withdrawal are about 2.5 times as likely to be readmitted within 30 days of discharge compared to uncomplicated term infants. We also need to think about the life course. Thinking about the life course and stepping back, I first saw this in a SAMHSA piece from 2009. And one of the key pictures is that we focus a lot on birth. We see, babies, and we respond to that. But as SAMHSA has found, there's around 440,000 substance-exposed infants born each year, and we identify about 5% at the time of birth. So you can imagine just intervening at the time of birth is not only ineffective, but it's also inefficient. If you respond just in my neonatal intensive care unit, you're missing opportunities to engage the mother and engage more upstream. So beginning in pre-pregnancy, public health systems to prevent opioid dependency, such as bolstering prescription drug monitoring program and ensuring access to treatment even before pregnancy, and decreasing the proportion of unplanned pregnancies to women who use opioids, again, as was mentioned earlier, that have a much higher rate of unplanned pregnancy. Prenatal, improving identification of substance disorders in pregnancy, decreasing overprescribing of pregnancy. Some recent work that we published, we looked at 110,000 births in Tennessee. More than 30,000 women had at least one prescription for an opioid. And we found an indication in about a third of the cases. Again, opioids have their place, but we need to ensure that they're necessary and appropriate when they're prescribed. Evaluate comorbidities in pregnancy, including things like hepatitis C. It's not uncommon for me to accept a transfer or see an infant with neonatal abstinence syndrome, and hepatitis C hasn't necessarily been thought about. And I'd continue to identify targets to reduce harm to both the mother and the infant. Next, in the neonatal period, improving identification of at-risk infants. We still struggle with this. Decrease transfers to tertiary care facilities and even to NICUs. As much as we can keep the dyad, the mom and the baby together, we know that improves outcomes for both the mom and the infant. And improve care standardization and decrease variability. And then childhood and beyond, decreasing the readmission risk that I mentioned earlier, begin to understand the long-term risks, and find modifiable risks. How much is the treatment that I'm doing in my NICU affecting long-term outcomes? I'm worried about some policies or some protocols that end with an infant being discharged home on a very long medication taper. What effect does that have on an infant's long-term development? I think those are important things for us to begin to look at. Well, in closing, both clinical and policy approaches to opioid use disorder and neonatal abstinence syndrome have been variable and not always supported by the evidence. But progress is being made at all levels of government and the healthcare system in understanding opioid use disorder and neonatal abstinence syndrome. Future efforts to improve care for women with opioid use disorder and neonatal abstinence syndrome should be grounded in public health principles. Thanks very much for your time.
We now have time for questions, and we're going to start with Susan Laird, who will talk about some opportunities for the audience, our virtual audience, to ask questions.
Yes, we take questions via our Grand Rounds email box, which is grandrounds@cdc.gov, also via Facebook and Twitter, and we have a lot of interest in this topic. So shall we start with one question we have? Policymakers often mistake research identifying risks of harm with research finding causation. Could you please address why the distinction matters, and to what extent researchers and health experts should be aware of the policy consequences of not recognizing and anticipating this common confusion?
So I'll ask Dr. Patrick if he would like to address some of this.
Sure, I think there is an important distinction between association and causation, and unfortunately, much of the work that we do does rely upon looking at associations, and I think that we do have to have caution before making big conclusions from this, and in part, there is some importance to the nuance that we share as researchers to both the public and to policymakers in interpreting some of these data. And I think part of that's just an ongoing conversation. It's important for us as researchers to be able to translate our findings to the public and also to have a skeptical eye about our own findings and their limitations.
Another question from the virtual audience?
NAS is a tip of the iceberg disorder. How do you see that local health departments can leverage public health responses with their primary care systems? What about leveraging healthcare reforms?
It's a good question. Well, I think part of the issue is how we increase awareness within the community in terms of public health practice, and I think there are some really good opportunities for us to think about local public health departments.
I think we also have to view the opportunities that we have. So, for example, this may be a very important intersection between the healthcare system, pregnancy that is, and the mom or the patient. And so what we've been trying to advocate is to take advantage of that and to find the people who can benefit from some assistance and treatment. And this, of course, would carry on to after pregnancy and to subsequent pregnancies, and in general, the lifespan of both mom and her offspring.
I would just say, too, I think there are some nice models of both public health, local public health departments, as well as fairly qualified healthcare centers that have modeled programs, including Jellicoe, Tennessee is one that comes to mind, where it's an FQHC that provided wraparound services for women with opioid use disorder in a rural community. Such a critical role in expanding access to care in those communities. And as far as health reform goes, one of the things that Health and Human Services was really hopeful for was that the combination of mental health parity as well as the Affordable Care Act would lead to expansion of both mental health and access to substance use treatment by about 68 million people. one of the problems that we have is not every community has expanded Medicaid. And so one of the key pieces is expanding coverage, I think. Expanding treatment is expanding coverage in communities that haven't to date.
Right. There are also opportunities with the use of Title V and opportunities to reach out to pregnant women and families, and local health departments can also identify with their own data which populations are vulnerable. Is there anyone in the audience who has a question? There are microphones at the back on each side. Okay, we'll take more questions.
Okay. Dr. Frieden mentioned more real-time rapid surveillance is needed, and there are some new CDC RFAs coming on board. Please update us on some of the new, more innovative approaches for more rapid surveillance.
Do you want to talk?
So I'm not sure if that means rapid surveillance of NAS or rapid surveillance of opioids. We have some folks in the injury center here, so I don't know if they know of any RFAs related to this issue.
Yes, this is Grant Baldwin from the Injury Center. We just are completing funding opportunities for enhanced opioid surveillance. We're going to be funding about 12 states to improve both the data quality and timeliness of data collected, and that includes things like improved syndromic surveillance as well as data around EMS runs for naloxone administration. So we're working really hard with the hardest hit states to improve data collection.
We have a question from Colleen Boyle.
Yes, can you hear me? Okay. Thank you. This is a wonderful panel, and thank you very much for the great information. I had a question for Dr. Patrick, and this had to do with your your state law that had some punitive aspects to it. And I was wondering if there had been any documentation on the impact of that law and anything that, because I know this is an issue that's come up with other states and with other conditions, so I'd love to hear some more about that.
Well, I think there have been anecdotal stories, and I've certainly heard women tell stories of not seeking care and even delivering outside the home in a car. As far as data goes, I've not seen any sort of compelling data that's really rigorously evaluated that. In part, the law just sunset a couple months ago. So I hope it is something that we begin to look at. And as we think through a public health approach, we think about how this is an ineffective approach. I mean, we have some data to suggest that most of that data is from qualitative interviews of pregnant women. I do think it would be helpful to have some evidence of the impact, just natural history to look and see what's there. And I do think states should be cautious. There are other states, North Carolina and Missouri, as I recall, that had similar legislation, and states really should be cautious about this approach, particularly in the setting of driving people away from care and no available treatment.
Yes, more questions, Susan? Oh, we have someone at the podium. Thank you.
Joe Sneesick. A question about the evidence for Asperg for opioids. It's my sense it's not all that strong, so I was surprised to see it. So can you comment on the evidence for the effectiveness of Asperg for opioid use?
You're correct that the evidence in support of Asperg for opiate use is not that strong. I would prevail on some data from our lab where we screened, and this was a NIDA-funded study, which is not yet published, and that's the reason I didn't have a slide, but we did find in a reproductive health setting overall that Asperg enhanced abstinence for a variety of substances, including opioids, although the numbers of opioid users was very small. So one of the limitations that we see, particularly for this population, is the numbers, and we just don't have numbers that are as high. I think the second component of this is in contradistinction to other substances, we have strong advocates for using medication-assisted therapy for opiates, and that means people are generally referred to a treatment center, whereas for other substances, we don't have as rigorous a system for referring people. But you're right, the data for experts is not as strong as, for example, ethanol or nicotine.
Other questions? We'll go back to our virtual audience.
We have time for one more. This is a long-standing epidemic in the U.S. Public health cannot be effective without more resources. What can we public health professionals do to help in this cause to find more resources via Congress and our states and through leveraging with healthcare efforts?
So I think the opportunity to increase awareness has been really very important. And I think some of the opportunities that are coming up with regard to funding will help to increase the evidence so that we can really address this issue. I think as what's been discussed here today is that it really is going to take a broader effort beyond just the infant, but larger groups in general.
And if I could say, I mean, I think calling your member of Congress about funding for the Comprehensive Addiction and Recovery Act is an important piece. And if you look at what we spend federally for child welfare, it's stayed relatively flat over the last several years. And funding for that specific part of CAPTA that I mentioned is exceptionally small. It's a little more than $2 million for the state of California as a whole. So I think there really does need to be more resources. And part of it is just conversations like this, us realizing that there's a problem and communicating that to policymakers.
That's all the time we have today. Thank you very much for joining us, and see you next month for Public Health Grand Rounds.